teenagers. So I'm just going to run through a couple of things. First of all, more generalities, and we get into what we see in teenagers. I think the most important part of a talk like this is the Q&A, and it's great that we have a bunch of questions here already, which we'll work through as I'm requesting any further of your questions. And I'm also conscious that when I speak to a group like this, that there's a lot of people in this audience that know an awful lot about migraine anyway already, and many of them I'm telling them things they already know. So bear with me, and I'll just run through a few points that I think are relevant in terms of this topic, and I'm happy to discuss as much as we can at the end of them as well. So if you look at migraine in childhood, I mean, you see variable instances, but I've seen it up as in general, a figure around 9% is taken. And then if you look at adult men, it's 6%, and as you know, it's greater in women, it's 18% of women. And I think people often ask me, how early can you diagnose migraine? And it's a question of any age, really, because we have these migraine equivalents in younger children. But in terms of classic migraine, it certainly comes later. Obviously, the younger the child, the more difficult it is. And then there are some different syndromes that we see more in the very young child. And that's not the topic of this talk. But in general, in young children, we expect a fair percentage of them to grow out of their migraines. And the treatments are analogous and similar to what we do in adults. So I suppose the difference in the young children, certainly vomiting is a much bigger feature, nausea and vomiting, often shorter headaches, although very intense. Dietary influences making not as much a big difference in the young population. We have these migraine equivalent syndromes in young children, which again is not the topic of this talk, but we have a number of unusual, funny types of episodic things that we see in these young children, paroxysmal torticollis, paroxysmal vertigo, that then may grow into migraine when they're older. So the younger the child, the more detective work we have to do, because they can't talk to us, or they can't talk to us in an articulate manner about their symptoms. And then if you look at what the breakdown we see, migraine with aura around 40%, migraine without aura 55%, and I'll talk a little bit about them down the road. And then I mentioned these other migraine equivalents, which are all individually, I'd have to say, quite rare. The diagnosis, again, as you all know about migraine is entirely based on a history, the story of what happens in the events. There isn't any test for migraine, adult, pediatric, or in teenagers. We listen for the typical features of the migraine. We want somebody who has returned to normal in between attacks. The episodic nature is important. The family history is very valuable. They will have a normal examination. And if we're confident in the diagnosis, I don't need to be doing brain scans, et cetera. If I meet a child, we're to be confident in the diagnosis of childhood migraine. I trained with a guy called Arthur Prinsky in the States a long time ago, and his criteria were one of the original set of criteria for childhood migraine. And he quite simply said any 3 of 6 features: if it was one-sided, throbbing, if there was an aura, if there was relief by rest or sleep, if there was nausea, vomiting, or abdominal pain, or family history of migraine. And that actually was quite popular in the United States and elsewhere. And then, of course, the International Headache Society have kind of refined it and have internationally agreed definitions. And with aura, then you can have these reversible aura symptoms, zigzag lines, flashing lights, blurred or darkened vision, dizziness, unsteadiness, and many, many other forms of aura. And then without aura, then you've got to have other features that make it a migraine. And these are the features. They have to be at least 30 minutes long, up to 2 days, 48 hours. 2 of the following 3, one-sided, pulsating, worsened by exercise. And during the headache, 1 of the following: nausea, vomiting, or inability to tolerate light or noise. Now, I'm not usually sitting in the clinic saying, okay, they've got A, they've got B, they've got C, or they haven't got D. I'm usually listening to the story and saying, yeah, okay, that's migraine. Next, please. In real life, that's how we do it. But obviously, these criteria are very important, I think, in terms of having a uniform way in which we make diagnoses from the point of view of research, et cetera. And it's important to listen for all of these features. So as I said, we have these other things, and somebody put in a question about abdominal migraine, and I'm happy to maybe address that at the end. These are things we see in young children. The abdominal migraine is mostly a feature of young children, not of teenagers. So I'm not going to make it part of my main talk. I'm more than happy to answer the question about it at the end. Cyclic vomiting, then repetitive vomiting, and these other migraine equivalents, paroxysmal vertigo and torticollis, which are rare things that we see in little kids. This is a history of one child that I followed, and that this child is now an adult in her 20s, I think. That shows how long I've been around at this game. But at 11 months, I met her with benign paroxysmal torticollis. And then at 24 months, they were coming back and they were quite severe, so much so that we had to use medication to try and prevent them. And then she was hospitalized with severe vomiting. And then somewhere beyond the age of 4.5 years, she had episodic severe stomach pain with vomiting. And then at 14 years, this girl had classic migraines with the usual headache features. So that's one person's life. And I remember meeting the child when she was a toddler, when she was presenting with this paroxysmal torticollis, which is a pronounced neck tilt, which she would have associated with vomiting, and saying to the parents, look, she may grow up to have migraine. And she did. Not everybody does. So it just illustrates the lifespan and what we see. And so what are we seeing that's different in teenagers? So first of all, as I mentioned earlier, after puberty, migraine is much more frequent in girls and women. So when I meet a child with migraine, I say to the parents, look, there is a very good chance your child will grow out of their migraine, but it's much greater if it's a boy than if it's a girl. And then I suppose also there are migraines related to the menstrual cycle, catamenial migraines, that's the official jargony medical term for that. And there are more prolonged headaches, and there's less of the vomiting and the tummy symptoms. And then sometimes teenagers and adults can develop into a chronic migraine syndrome with an everyday headache. And I'm going to talk a little bit about that because I do see a fair bit of that. Beyond early childhood, then the main syndromes are these three: the migraine with aura, which we've discussed the criteria, migraine without aura, and the chronic migraine. And the other difference is in adolescence are these higher rates of inflammation, associated asthma, allergy, higher rates of epilepsy in older children with migraines. So they have a higher rate of epilepsy than you might expect in the general population. Doesn't mean that somebody with migraine has a high risk of epilepsy. They just have a higher risk of getting epilepsy than the general population. They get more associated nightmares. They often have a history of motion sickness, and mood disorders, depression, commoner in older children, teenagers who have migraines. So there's a question on there about hemiplegic migraine, and I might as well discuss it here. I suppose hemiplegic migraine is where you get a weakness down one side. A hemiplegia is a weakness down one side, and it is relatively rare. There are familial hemiplegic migraines. So it's a disorder whereby there are known genes. There are 3 known genes, and where you have a clear family history of other people in the family that might have migraines, where they would have had a weakness down one side with their migraine. And one can go look for those genes. It's not necessarily always necessary or valuable to test the gene. You've got a clear diagnosis and a clear family history. It's very scary, obviously, if you get weakness down one side with a migraine. The treatments are kind of similar to what we normally do for other migraines. The hemiplegia goes away, but obviously a very frightening and scary event when it happens. Confusional migraine, which is just another neurological deficit with the migraine. So it's affected the brain such as to cause acute confusion. I've certainly seen that a number of occasions in children and teenagers. There's a condition called ophthalmoplegic migraine, where there's paralysis of movement of the eyes. Now, actually, that's being changed. It's got another big mouthful of a medical name: recurrent painful ophthalmoplegic neuropathy, mainly on the basis that people don't think it's migraine anymore, that it's a separate entity. And I suppose I have actually seen teenagers who clearly had it as part of a migraine and also had migraine, but I've also recently actually have another teenager with this condition where it's not migrainous. I think both can happen. I think, but the official literature says we can't call it migraine anymore, but there you have it. I think there are still some people with migraine who get this recurring paralysis of movement of their eyes as part of their migraine. And basilar migraine implies that the basilar artery distribution of the brain, which serves the base of the brain, the brain stem, and symptoms you can get with that include blackouts, very prominent visual symptoms, dizziness, vertigo. Those kind of symptoms can happen with basilar migraine. So they're all more unusual, but all very frightening episodic things to happen in a teenager or a younger child. So chronic migraine. When headaches occur for 15 or more days per month for at least 3 months, and there's migraine headache on at least 8 of those days. This is the official definition of chronic migraines. So you may be having tension type headaches on the other days. I suppose this is a pattern that is well recognized and I see often. And it is also, not always, but can be related to overuse of over-the-counter pain medication. That if you're using somebody with headaches, including migraine, where they're getting a lot of over-the-counter pain medication, you can get this medication overuse headache that leads to a chronic migraine type syndrome. So I think it's important to say that I've certainly seen this, but I also see teenagers who have chronic headaches who do not have migraine. And sorting those out, I think, is important because obviously there's lots of treatments for migraine. We have less treatments for those other teenagers. So the other known headache syndromes, and if you look up the International Headache Society criteria, there's a thing called constant daily headache. Now you might all say, well, that was a really clever diagnosis, constant daily headache. That's what I've got, doctor, a constant daily headache. But that is actually a recognized syndrome. And unfortunately, I've seen many teenagers with constant daily headache. I'd say 90% of them don't have migraine. And it's a pattern of an everyday headache. There's probably more of a tension quality headache. It can be a really difficult problem. Limited therapeutic options for those teenagers. They have really disruption of their daily life, school, sports, etc. because of it. And really the focus with many of these teenagers is really non-medical, and it's about learning to some degree to live with it, avoid the frequent use of pain medication, and just having normal life, including normal school, normal sports, normal other activities, finding stress relaxation techniques. And that's really a lot of what goes on in teenagers with the diagnosis of constant daily headache. You could say, do some of these kids have mood and anxiety disorders, and is that why they have headache? I think some of them, but certainly not all of them by any means. And some of them are very, heroically getting on very well with their lives, but plagued by an everyday headache. And then there's another entity called new daily persistent headache. So that's the person who didn't have any headaches, and then suddenly they often maybe beginning after a viral illness started having an everyday headache. And I've certainly seen that many times in teenagers also. Again, a difficult thing to manage. And again, we get to a point where we're avoiding the frequent use of pain medications, and we're looking at really non-medical approaches and normalizing of life. So they're kind of the 3 chronic headache syndromes that I see in teenagers. And look, I'm always glad if I can establish it as a chronic migraine, because I have a lot more things I can do for a chronic migraine than those 2 other syndromes. So I think just to think about other things, and these are things that families worry about. Chronic headache in teenagers, sinusitis, almost never in my experience, very much an overdiagnosed. Sorry, I went down a slide by mistake there. Pretty much never is a chronic everyday headache due to sinusitis. I put it on there because it's on the list. There's not really, there are other rare things that we think about, abnormal collections of blood vessels in the brain. Everybody thinks about brain tumors. Thankfully, that is an extremely rare cause of headache in my practice. I'm at my line of work approaching 30 years now. I can number on one hand, less than the fingers of one hand, the number of children with headache who turned out to have brain tumors in my practice, thankfully. Accumulation of fluid in the brain called hydrocephalus. Again, rarely does that present to me with headache. If I have somebody who I already know has hydrocephalus, that's a different story. There's a condition called benign intracranial hypertension, which is an important condition to diagnose, and that certainly often presents with headache. and is often seen in teenagers, particularly, say, more in girls than boys, and particularly if they're carrying extra weight. And it's seen particularly in young adult women as well. High blood pressure, again, rarely if ever a cause of headache. Rare metabolic disorders, once or twice I've seen that. And the temporomandibular joint, often blamed for headache. Again, it's often hard to know whether it is or isn't, but that is something that can be a cause of recurring headache. Sometimes disruption of that's the joint at the angle of the jaw where it joins with the skull. So when do we go looking into headaches? When do we do a bunch of tests and when do we not? Well, if somebody has an abnormal neurological exam or, has presented with a very abnormal neurological symptom, then I would be inclined to investigate, including possibly a scan. As you know, migraine headaches are typically often one-sided unilateral headaches, particularly more in the older kids and adults than in the small kids. But if it's always the same side, that often raises a little flag. If they're having very prolonged headaches going on for days and weeks, if they're having headaches that wake them from sleep at night, actually, I wrote that wrong, that is often regarded as a quote red flag about headaches. Headaches that are worse by coughing or sneezing may be a sign of a high pressure type headache. So those are situations where one might feel that one might look into it a little bit more. So I suppose the next thing to talk about is the cause of migraine. And when I was in medical school, there was a vascular theory about blood vessels causing migraine or abnormal constriction or expansion of blood vessels causing migraine. That was discarded many years ago. And now what do we know? We know that migraines begin in the brain and begin with some kind of neurochemical event in the brain. And this is where actually what I mentioned earlier, the hemiplegic migraine syndromes, although they're rare, because people have found the 3 genes that cause familial hemiplegic joint migraine, that's a basis for doing a lot of research in animals where you disrupt those genes and see, well, how do those animals get events that look like migraine? How are they caused? And likewise, there's scans that can look at how migraines evolve in human beings. That I'm going to show you one of them in a minute. So I think the other thing important to know about headache is that the brain is not a pain-sensitive structure, but the skin, the bone, the muscle, the teeth, the lining of the brain, the meninges, which is kind of a little membrane around the brain, the blood vessels and the nerves, they are pain-sensitive. The brain itself is not pain-sensitive, which is why you've seen on documentary programs where somebody's doing a brain surgical procedure and they've woken up the patient to try and stimulate sensitive structures to figure out exactly where they are, and they can have the patient talking in the operating room. Why? Because the brain itself doesn't feel any pain. So in general, we feel that there's an electrical event happening in the cortex. That's the wrinkly surface of the brain, and that leads to release of a cascade of chemical substances, and that causes inflammation in the meninges around the brain, which causes the pain. What happened there? There we go. This is an actual picture of a scan where we see evolution of the beginning of a migraine in what's called a PET scan, a way of looking at blood flow or other forms of metabolism in the brain. This is somebody's migraine evolving as we look at it while they're in the scanner. So again, this simplified diagram would say that the green arrow here is the beginning of the migraine. It can measure the cortical spreading depression. If you're looking electrically at the brain, you see the voltage in the brain going down, and it's kind of spreading evenly over the brain. And then you get release of a lot of these little ions and chemicals that cause irritation of the meninges, which are pain-sensitive structures, as we've said. And then that goes back up. The person experiences pain via the nerve endings around the meninges. And then that leads to a bit of a vicious circle whereby more is produced, and you've got a bit of a vicious circle where you get an evolving migraine. So the brain event is what gives you the aura, the neurological features of the migraine, which could be something like the hemiplegia, or could be visual symptoms, etc. So that's the general concept that still prevails about what happens in a migraine. So I mentioned the genes in the hemiplegic migraine, and what they do, they work on ions transport across cell membranes and some chemical processes, and they've been valuable in trying to figure out. Unfortunately, they're only a tiny percentage of people with migraine. Most people with migraine, even though we know migraines run in families, we don't know what those genes are for the majority of people with migraines, and it's probably multiple genes in one person. And as I said, they're means of studying the migraines. So what are we doing in teenagers? Well, we're reassuring the children and their families, the teenagers and their families, that there's nothing bad wrong with them. They have migraine, and there's nothing else bad wrong with them. We get them to keep a diary. We look at diet, look at lifestyle, look at stress, look at sleep. You all know about the main dietary factors that can sometimes be factors for migraine, including, in particular, in teenagers and children, chocolate and cheese, some food additives, citrus fruits, etc. And I'm sure there's some people in the audience can add some dietary factors of their own. Lifestyle, in particular, not missing sleep, and in particular, looking at stressful factors in life. I mean, the type A personality child or teenager who is a migraineur is a bit of a cliche, but I've certainly seen a few of them over the years where they're, high achieving or highly competitive people in their sport and their academic school activity, etc. And that can be certainly a contributory factor in some children with migraines. And I think where it's available, any means of relaxation, any means of counseling in terms of people how to manage their pain and their symptoms and biofeedback, that can be valuable. And then there's medication, which I would separate into whether we use it acute medications or preventive medications. So we talked about the dietary factors. We've talked about not skipping meals, avoiding low sugars, not skipping breakfast, not skipping lunch. We've talked about having a good sleep pattern, generally reducing caffeine intake, although there are rescue medications for migraine that include caffeine sometimes. And then we would usually say paracetamol, being a well-known painkiller that we can all buy in a corner shop at an appropriate dose early in the symptoms, is probably the best first-line treatment for an acute migraine. Now, a lot of people would say, well, that doesn't work well for me. Brufen or something like that works better. So non-steroidals like ibuprofen or naproxen are also used. The important thing to know about those drugs is they can cause tummy upset. They can cause a risk of gastritis or stomach bleeding, etc. So just to be aware of that. But many people will say to me, look, this works better. Nurofen would be a common trade name for ibuprofen, plenty of other trade names out there as well. And look, it's about what works better, because you want something that works and you want to get it in rapidly when the pain is beginning. If you can get anti-vomiting medication into the person, if vomiting is a big part of it, promethazine, 12.5 to 25 metoclopramide, these all have trade names, and I won't go into the trade names. And then there's some specific anti-migraine acute medications, the triptans being the ones that we know all about. And in children and teenagers, I have historically used sumatriptan, which is the common trade name for that is Immigrant. Why? Well, we're conservative when we take care of children and teenagers. We tend to use the old, tried and trusted methods. Most of what we do in children and teenagers in pediatrics and in pediatric neurology is something that was discovered originally in adults, and we're applying it to them. So we're tending to use the older and more tried and trusted treatment. So certainly sumatriptan, which was the first of the triptans and probably the best studied, one of the best studied in children and teenagers, is the one that I would use most. It can be given as oral swallowed tablets, but there are better ways to give it to get it rapidly into the system. I particularly like using the single-use nasal spray because it's bypassing the stomach if you've got a child who's got nausea or vomiting, and you can get it in there rapidly, provided the child or teenager will tolerate having it squirted up their nose. I mentioned earlier, or maybe didn't, that one of the mediating factors of pain and migraine is a chemical called CGRP. So the triptans work on other chemical receptors in the brain called serotonin receptors, but they seem to have a benefit of normalizing the elevated levels of CGRP, and that is probably how they reduce the pain of the migraine. And of course, whenever a drug company produces something, other drug companies produce other Me Too type products, and there are a number of other triptans out there. And this is the main, zolmitriptan, naratriptan, rizatriptan, amitriptan, provatriptan. They have their own trade names like Frovex, Zolmic for zolmitriptan, etc. I have certainly used some of these other triptans, particularly in some of the older teenagers. And I think what's well known is that if one doesn't work, maybe one of the others will work. So it can be well worthwhile trying other triptans if the first one that's prescribed is not working. So I think most people in the audience probably know about this thing called analgesic rebound headache, and actually that's a dated term. I should have changed that slide. And the common term used now is analgesia overuse headache. So the idea is that if somebody is getting a lot of over-the-counter pain medication, that actually can make the headache worse. And that can happen also with triptans if you're using a lot of triptans. It can lead to sensitization of some of the nerve cells in the brain. This can lead to a worse headache, kind of rebounding when the medication wears off. And in general, we would be saying to families of children and teenagers with migraine to be limiting the use of these medications to 3 per week or less. I would often say 1 per week to people, and then wouldn't get too upset about twice a week, but not to be getting into a situation over an every day or multiple times per day use these medications, certainly when you're into a long-term situation. So I think the important thing to know is that I'm talking a lot about these medications, but it's not that I can use a whole lot of them. And preventive medications are medications you take every day. So they're medications that are there to prevent migraines. So they're not something you swallow when you've got a headache. And obviously any medication you take every day has some potential or risk for possible side effects. Nobody likes to be taking a medication every day unless they really need it. So when do they really need it? I suppose if somebody is socially disabled by their migraine, if they're missing a lot of school, if they're missing out on their sports or other physical activities, if they're having very frequent severe headaches, it is perfectly reasonable to offer that family a preventive medication. And I'd always regard it as a two-way process. I'm sitting in my clinic talking to the child and the parent. It's up for them really to decide, is this problem bad enough that warrants doing something like this? And obviously we don't do it for life. I would often say it would work, we'd continue for at least 6 months and then find a suitable time in the child's life to take it away. I wouldn't be taking it away a month before a major exam, etc. Sensible stuff like that. So I think there is a place for it, but it's certainly a last resort rather than a first resort. You put people on preventive medications for migraine. So the oldest ones are the beta blockers. They are blood pressure medicines and they're used for heart as well. They certainly are used. The commonest first line I would use in children and teenagers is Botulinum. Trade name of that is Sana Migraine. And then there are other classes of medications where if we're in a tough situation and Dravet didn't work, that we might try flunarizine. I certainly have used a fair bit. It's called a calcium channel blocker. I have rarely used some of the anti-epileptic drugs for migraine. In particular, I have used topiramate in the past, which is Tocilix. I've used some of the other ones that are listed here. There was a really good multi-center study in the States. And in the States, they said, okay, well, what are the commonest preventive medications we're using for migraine in children? And they said it's actually topiramate, which is an anti-epileptic drug also, but has been established in adults as a treatment for migraine, and amitriptyline, which is a low dose of a well-known antidepressant, but it's used as a pain medication. And they found really that neither of these were better than the sham treatment, the placebo. And you get high rates of placebo efficacy in conditions that cause pain. So I'm not using as much topiramate as I used to. I never really used amitriptyline for migraine. I used it for constant daily headache, but I never used it for migraine. I think in teenage migraine, then certainly over 50% of situations, it will go away, remit. But unfortunately, as I said earlier, post-puberty, there are many more teenage girls and women with migraine than there are teenage boys and men. And 60% of women will relapse in their 30s. I often meet a parent of a child I'm looking after who has migraine herself and would say, I got migraine during my pregnancy. That seems to be another common scenario. I don't take care of adults, so I can't talk much more about that, except that that's what these women tell me. If you have more severe migraine as a teenager, you're more likely to have a problem persisting into adulthood. So overall, migraine is a common problem in teenagers. Most of them don't need complex medical tests or treatments. I think recognizing the diagnosis and reassuring people is important. And many of them, that's the main step. And then looking at lifestyle measures that we've mentioned, looking at identifying stressors and factors in their life that are triggering migraines, promoting relaxation techniques or things that help them individually to relax. And many of them will get better with age. But as there is a small percentage that will evolve into a chronic headache pattern. And certainly in the chronic migraine group that I'm looking at, you know, I'm looking at all of these other measures to try and improve their headaches. I'll briefly talk about things that I know very little about because they happen in adults and I don't do them. But I'm chatting with Deirdre before. I suppose these are things that are new, that are exciting in migraine, that are available for adults. Botulinum toxin, one of the commoner trade names for botulinum toxin is Botox, but there are a couple of other products. That is a medication that weakens muscles. You inject it into muscles and it weakens them. That's how it makes wrinkles smooth when people use it for vanity, for their cosmetic use. I've used it before for treating cerebral palsy in children who want to weaken specific muscles that are too tight. And likewise, if you inject it into a number of scalp muscles, it can improve migraine, and it's been shown in studies to do so. And then nerve block, where obviously all pain is mediated by nerves. So identifying the major nerves from the scalp, and the occipital nerve is one that takes a lot of the input from the scalp and the cranium. And if you block that nerve, you stop the pain. So we're all familiar with the idea of a nerve block of, say somebody's getting a procedure done in their arm, or getting an operation done, or maybe getting a fracture reset. Where they can get a nerve block, you can block the nerve so they won't feel pain. Or when the dentist is working on your teeth, he or she can block specific nerves by injecting anesthetic into those nerves, and so you numb them. So the same thing can be done, and it can be done for migraine, and it's done for other forms of headache as well. And then the other really exciting product are the anti-CGRP antibodies. So I mentioned earlier CGRP as being this, you know, chemical that gets released that is part of how the migraine evolves when it's inflaming the meninges, the surrounding of the brain. So first of all, they said, okay, let's produce medications that block CGRP, and there were a medication called talsegapant, and there were a couple of other similar ones. Unfortunately, they never really worked out. They had side effect issues, and they weren't hugely effective. So they never got to being great treatments for migraine. Now, these people are still working on those. But then another approach was to say, okay, you can make what's called a monoclonal antibody that can help. So this is the slide about Botox, and I mentioned it, and I think the important thing to know is that Botox wears off, and you've got to repeat it every 12 weeks. Certainly, that's three. When I'm treating other things with Botox, you know, generally the effect of it is somewhere between 3 and 6 months. But obviously, you could break the cycle of a bad migraine situation, and maybe wouldn't necessarily have to keep going back every 12 weeks. But with a reduction in the number of headache days per month shown, and not necessarily a complete resolution. And then the monoclonal antibodies, as I said, in a lab, they generate via techniques using cellular manipulation to get a bunch of immune cells to make an antibody that's directed directly at the CGRP chemical or the receptor where it acts to create the pain. And so this is done by injection, by regular injections. And there is one product approved in Europe, and I know adult colleagues have been using this. Well, I personally have no experience with it. It's not licensed in children or teenagers, and I have no experience with it. And there are a number of other Me Too IMABs out there being produced and under study. You know, so I think that this offers huge hope for adults who are you know, disabled by very frequent migraines, and I would hope there will come a point where that option is available for teenagers. So I suppose overall, certainly compared to 20, 30 years ago, we understand better how migraines happen. And there have been some new treatments that have come along over the last 20, 30 years that have been directed at the mechanisms of how we understand those migraines happen, including, as I said, the triptans, which have been around for a long time now, including the anti-CGRP medications, which didn't work very well, and now these monoclonal antibodies, which seem to be showing reasonable efficacy, although not perfect resolution. So I think there are exciting things happening, and they're coming down the track. Unfortunately, not available in the age group I take care of at this point in time.